Good evening, ladies and gentlemen, and welcome to another session of Intellectus Campus. The directions for how to manage the call are on the chat. I hope you're all familiar with Zoom. Because of the problems with multiple people unmuting their mics, what we will do is if somebody does unmute their mic, they'll be removed to the waiting room and then either let back in when they're muted or removed from the call. And I'm sorry that we have to do this, but we do have international speakers and international listeners on the call and people from all over the region. And we really do need to ensure that everybody is able to listen without interruption. So without further ado, those of you who have seen my bio will have seen it on the group. My name is Dr. Jackie Stone. I'm the scientific lead and scientific director for Intellectus Campus, and I'm in charge of innovation and research. And I welcome you to this session of Intellectus Campus. My background is I have a medical degree, I have a physician's qualification, I'm qualified in aviation medicine with a diploma and a fellowship, and I also have an honors degree in medical biochemistry, and my real interest is infectious disease, and my other interest is in teaching doctors and scientists and healthcare professionals how to think for themselves, and particularly when we start looking at African solutions for African problems. So this forms part of our infectious disease group of lectures, and it falls under combination therapy. We've covered Helicobacter, we've covered HIV, we recorded TB today. It will be presented next week. This particular session will be on coronavirus, and we will be doing leprosy as well as part of this session. So I welcome those of you that are interested in infectious disease. And the objective for today is to take you through how trials are structured and to get us to start to look at things like the Solidarity trial and decide whether we want to be part of a global trial or whether we shouldn't be looking for solutions in our own backyard. So I'm going to go into the Solidarity trial. I know there's a lot of interest in it. I know that they're recruiting. There's 52 different countries involved, and I'll get into the Solidarity Plus trial in a second. But I want to show you the biggest clinical trial in the world. And because we're discussing controversial issues, I'd like to discuss whether we think that this is, in fact, the correct way to go, or whether Africa should not be doing things slightly differently. So the Solidarity trial is divided into a number of arms. In May 2020, they started with the Solidarity trial for vaccines, but we're going to focus on the Solidarity trial for treatments. And it's a multinational phase 3 to 4 trial, and it is organized by the World Health Organization, and it compares 4 untested treatments for hospitalized people with COVID-19 illness. And the trial was announced on the 18th of March, 2020. And by the 6th of August, 2021, 12,000 participants in 30 countries had been recruited to participate in the trial. And the treatments that were being investigated at the time were remdesivir, sorry, there's a typo there, lopinavir, ritonavir in combination, and the two drugs combined with interferon beta. Hydroxychloroquine was included, but in June 2020, they concluded there was no evidence for its effect, and I'll go into that a little bit later. So one of the things that the trial was then said to have produced conclusive evidence on the effectiveness of repurposed drugs for COVID-19. Now, the important thing is this is a very sweeping statement because there were very many other repurposed drugs for COVID-19. But the amazing thing was in 30 countries in 6 months, the world's largest randomized, double-blinded controlled trial generated conclusive evidence on the effectiveness of repurposed drugs for the treatment of COVID-19. Now, myself and Professor Ndurukwa and a group of international doctors wrote a paper on the Zimbabwean data, and it took us well over 6 months to analyze 104 patients. And the paper was finally produced on the 34 best results of those. And that took 2 years. So I find it quite amazing that they managed to do this in the space of time they did. Having announced the trial in March 2020, in October 2020, the WHO produced an interim report which concluded that remdesivir, hydroxychloroquine, lopinavir, interferon regimes appear to have little or no effect on hospitalized COVID-19, as indicated by overall mortality, initiation of ventilation, and duration of hospital stay. Now, I'm going to pause there, and I'm going to ask the admin team to please remove whoever's not muted off the call. Thank you. So, guys, can you please mute whoever's not muted? Thank you. So the final results of the Solidarity trial, which spanned more than 30 countries, was that these drugs appear to have little or no effect on 28-day mortality or the in-hospital course of COVID-19 among hospitalized patients. Now, Gilead, who manufactured remdesivir, objected to this, and it stated that the international nature of the Solidarity trial was a weakness. Many experts regarded it as a strength, but I would agree with Gilead that it is almost impossible to manage this number of countries and the researchers in those countries and get a consistent result. All you are going to do is to dilute the data, and it becomes very, very hard to analyze. And I didn't know that until I actually had to analyze my own data. The other point of contention is that remdesivir was granted emergency use authorization by the US FDA, and this was based on no clinical data. So the Solidarity trial probably raised more questions than it actually answered. And now we were told in August 2021 that the next phase, called the Solidarity Plus trial, will enroll hospitalized patients to test 3 new drugs. A variant of artemisia, which is used for malaria, amitinib, which is used for cancer, and infliximab, which is used for Crohn's disease. Now, the latter 2 of these substances are antibody-based, and they are biologics. And I find it very hard to believe that any of us in the region will be able to afford these drugs. But these drugs were selected by an independent expert panel under WHO. And it's important to note that WHO are an unelected body of people. And it's important to note that they are privately funded. 84% of their funding is private. And that the head of the WHO is not a medical doctor and has never taken the Hippocratic Oath. So the concern is that the results of this trial will be rolled out across Africa and globally, and policy will be determined based on these results. Now, the Solidarity Plus trial will have over 14,000 hospitalized patients in 52 countries with 600 hospitals and 2,000 researchers. Now, the paper that we did had 8 researchers on it, and I promise you, it was like herding cats. To get all 8 of us to agree on how a sentence could be worded could take half an hour. So 2,000 researchers on this trial. If this data comes out very quickly, I would be concerned because 2,000 researchers who all have an opinion will need to be heard. And 52 countries who don't necessarily have English as their first language will need to agree on what results are published on this trial. So we go back to our themes for Intellectus Campus for 2024. What are the advantages of controversy? And the biggest advantage is that it leads to better decision-making and problem-solving than you might achieve through consensus, debate, or individual effort. And it also helps protect us from logical fallacies and blind spots, because there are institutions that we've always trusted based on their track record. But the Solidarity trial, the initial Solidarity trial, to get those results in 6 months had to ring bells with people who understand research. And Dr. Brighton spoke recently on Ubuntu as a form of medical management. And if we can get the accreditation through, I hope he will speak to us next week on medical management models and Ubuntu as a model. But one of his slides says that trust arrives on a tortoise, and the other term is trust walks in and it gallops out. And the meaning of this proverb is it takes a long time to establish your credibility. And the WHO, as it was 40 years ago, took a long time to become credible. But when things start to become suspicious, trust gallops out the gate. And I think for a lot of young doctors, young nurses, young people who are listening to this call, a lot of us are starting to question our own sanity when we are told things that are very, very hard to believe, and we're expected to take them at face value and as though it is the truth. So the contentions, and these are not my contentions, this is based on a group of 77 doctors from around the globe. How did they get the analysis done so quickly, and how did they get it published so quickly? Why were they so quick to dismiss treatment? And why did they ignore the drugs that were supposed to be working? Zelenko showed that azithromycin, hydroxychloroquine, and zinc was effective as early as March 2020. And why were none of these drugs tested in combination? We're African doctors. We treat HIV, we treat TB, we treat Helicobacter. We never use monotherapy because it generates resistance and it doesn't work. So why was ivermectin, doxycycline, and zinc not tested in combination? Because that group was shown to start raising a positive flag as early as June, July 2020. So the real questions in 2020 really should have been, were any of these drugs better than doing nothing at all? And Dr. Eleftherios did a very elegant paper. He's a doctor of mathematics, so I don't understand about 3/4 of his paper, but he proved unequivocally that doing something, and that doing something might be antiviral, might be anti-inflammatory, might be antithrombotic treatment, but doing something, and in Zelenko's case, giving azithromycin, hydroxychloroquine, and zinc, was at least 8 times better than doing nothing. And that was actually the real question. The question was not whether there was sufficient evidence or not. The question was, is giving a safe therapy better, a safe, repurposed, and well-known therapy that is logical and has a mechanism of action better than doing nothing at all? So I just need to move something out the way. So if we go to the principal trial, which is the UK version sort of the solidarity trial, it is a clinical trial that evaluates potential treatments for COVID-19 in hospitalized patients, again, hospitalized patients who are already receiving standard of care. And it aimed to assess the efficacy of remdesivir, monoclonal antibodies, and interferon B in terms of their impact on all-cause mortality. So if we go through the principal trial, it is a very interesting trial because they advertised it as early as 2020. And the results were only published 2 years since the original planned end of the trial, which was blamed in delays in supply to the manufacturer. And the inability to supply ivermectin to the trial was denied by the manufacturer. The principal trial was funded by the British taxpayers under the National Institute of Health Research. So on the 13th of March, 2024, the doctors' groups were awash with the press release. A new study shows ivermectin lacks meaningful benefits in COVID-19 treatment. And so let's look at the Solidarity trial, which had multiple arms, and ivermectin was merely one arm of it. So the background was whether it impacts recovery, hospital admissions, and long-term outcomes in COVID-19. And this was contested because the WHO only recommends this drug in the context of a clinical trial. Now, the methodology was they took anybody over 18 years old, whether they had mild or severe disease, and anybody who had been sick for up to 14 days. And these patients were randomized to usual care or usual care with 0.3 to 0.4 milligrams per kilo per dose for 3 days as monotherapy. Now, as someone who has used this as combination therapy, I would not predict that this would be particularly effective. And I would almost say that this trial was designed to fail. And then let's look at the results. So this is a forest plot. And you can see that anything on the right side of this line, this purple red line, suggests that ivermectin is effective, and anything on the left says that it's not. And for all symptoms, the p-value is less than 0.01, that ivermectin is effective for symptom control. The interpretation of this result is that ivermectin for COVID-19 is unlikely to provide clinically meaningful improvement. And I don't know about anybody else, but for me, the data and the conclusion do not match. I've got a cognitive dissonance when I read that. And the author said, the results of the study add certainty to the existing evidence that ivermectin has no place in the treatment of COVID-19. And I don't know how many people actually read the whole paper because I've started doing that. But this and this don't match, okay? Now, the good thing about this trial and the very wide publicity surrounding it, because it was all over the Nuffield Department of Primary Health Services, it was all over the UK, and the statement was that the new study showed ivermectin lacks meaningful benefits in COVID-19 treatment. So, I'm a fan of Disney, particularly The Lion King and its music. And I think as critical care, discerning doctors and healthcare workers, we have to start reading the data and interpreting it for ourselves, because I'm definitely not okay with the interpretation of this study and the fact that people come to me and say, and give me the conclusion with having not read the the data. I love the clip which says, what's the shadowy place over there? And it's CNN. And when the head of the CDC is getting her information from CNN, we really do need to be more discerning about how we read the data. So I've put the link on here. And one of the critics that's on our group, who is part of Heart in the UK, he says much of the scientific literature, possibly half, may simply be untrue. There are people who have flagrant conflicts of interest, and they actually state that science, in inverted commas, has taken a turn towards darkness, and journal editors deserve their fair share of criticism as well. Our love of significance pollutes the literature with many a statistical fairy tale. Now, those of you that watch the mathematics in medicine presentation should be familiar that there is a huge difference between statistical significance and clinical significance. So Edmund Fordham has been very vocal on the Together trial, the Principle trial, and the Solidarity trial. And Professor Aldous has been very, very clear that we must not outsource our thinking. And even artificial intelligence says that while technology can assist us in gathering information and automating tasks, the process of reasoning, analyzing, and forming our own conclusions remains a uniquely human endeavor. We cannot afford to outsource our thinking. And the biggest mistake we make in Africa is that we assume that the civilized, advanced countries can outthink us. Now, the litmus test came for me on Sunday when a returning resident to Zimbabwe brought her children to a function, and it was very clear that people who've been living in the UK cannot deal with straight talkers in Zimbabwe. But I can guarantee you that most people in this group could walk into a function in the UK or the US and hold their ground. So we can transplant anywhere, but people have difficulty transplanting to where we are because the one thing we have is resilience. And if we didn't think for ourselves, I don't think that many of us would still be here. Now, my favorite sportsman of all time is probably Djokovic, but Kobe Bryant comes a very, very close second. And may his soul rest in peace. He passed on Australia Day, which was the 26th of January 2020 in a helicopter crash. And he is unquestionably my youngest daughter's sporting hero, and she played national basketball for Zimbabwe. So I love Kobe's comment to say that he's not here to do what's normal, because what is normal appears to be marching in lockstep to guidelines issued by people who have absolutely no idea of the demographic in which we work in Africa. And if we go to statistical normal, we've already discussed the difference between statistical significance and clinical significance. And normal does not mean optimal by any stretch of the imagination. So, sorry. So I'm just gonna, sorry, Brian, I'm having a couple of issues with the tech. I'm trying to go to the previous slide. So the principal trial on ivermectin is a good introduction to any student on how to intentionally fail a clinical trial for medical students. And I'm going to proceed to the following table, and you will notice that the author is exactly the same. What I'd like you to look at is that the delay in treatment is 3 days in molnupiravir and is 14 days in ivermectin. Now, if this was a malaria patient and we were testing Coartem or quinine or any anti-malarial, if we delayed 14 days on a malaria patient and then instigated treatment, we would not be surprised at all if they died or had amputations of their limbs and brain damage and renal failure. So to delay for 14 days on the ivermectin arm compared to 3 days on the molnupiravir arm makes no sense unless you're actually trying to fail the trial. The other thing that is interesting is that they only treated for 3 days in the ivermectin group, whereas they treated for 5 twice a day in the molnupiravir group. And the administration of the ivermectin was contrary to what is advised. So if we look at this graph, which is quite boring because it's pharmacokinetics, which never really interested me, but when we look at the pharmacokinetics of this, we will see that if you give tablets, the serum level after administration is 50 nanograms per mole. Whereas if we give, sorry, I don't know what I've done here. I'm going to just go through. So if we give tablets, we reach 50 nanograms per mole. If we give liquid, we reach 110 nanograms per mole. So why are we giving tablets in this trial if we already know that if we are going to be using 0.3 to 0.4 milligrams per kilogram, we should be doubling it if we're using tablets. In addition, they gave the tablets on an empty stomach instead of a fatty meal. So much was done, but despite giving too little, too late, in the wrong form, without food, as monotherapy, they still demonstrated a p-value of 0.0001 that this drug was better at alleviating symptoms. And Disraeli said there are lies, damn lies, and then there are statistics. And he was an extremely funny man. And one of the other quotes that I love is from Andrew Lang, which is when people use statistics as drunken man uses lampposts for support rather than illumination. And the important thing about this is that if you are manipulating the statistics to show you what you want, then you can actually show absolutely anything that you want. And what I'll show you on that one, I'm trying to go back to a previous slide, is look at the numbers of patients who were treated. So 25,783 patients went through the molnupiravir arm, and the publication delay was 4 months. 4,500 went through the ivermectin arm. What this is saying to any statistician is if you run enough numbers, you will get significance. And despite running less than 1/5 of the numbers, in fact, less than 1/6 of the numbers, they still showed that ivermectin basically had an effect. And as we can see there on the forest plot, nothing favors the placebo. So a letter to the editor was written regarding the solidarity and the principal trial. And there were 3 research questions. One was whether ivermectin shows a measurable statistically significant effect in mild cases of COVID-19. Now, the solidarity trial, we were discussing hospitalized cases. And the clear finding on one is it shows a measurable, statistically significant and clinically significant effect. Whether the resulting clinical advantage is meaningful is a completely subjective comment, and whether it is optimal is also subjective. So the finding that it's not meaningful was made on completely arbitrary grounds. And personally, as somebody who needs to function on a daily basis, if I'm better in 2 days, I'm going to consider that clinically significant compared to if I'm still in bed in 2 weeks' time. And optimality was never one of the questions. So while the principal trial reports that ivermectin is ineffective, their data actually proves efficacy. And the efficacy is clinically and statistically significant. So let's get to the Together trial, which was the most entertaining trial of them all. And I read the Together trial in Victoria Falls on April the 1st, 2022. I don't think it was published on that day, but I got to Vic Falls on that date. And I honestly thought that it was an April Fool's prank. And the reason was that the Together trial, which was renamed the It Doesn't Add Together trial, stated that there was no significant difference in the risk of death in the ivermectin group and the placebo group. There were 679 patients in each, and they were treated for 3 days with 0.4 milligrams per kilogram per day for 3 days of ivermectin. And I went into the actual appendices to find the data because I couldn't reconcile the 21 deaths in the ivermectin group and 24 in the placebo group made any sense. And the reason was that the New England Journal of Medicine and Ed Hills used the wrong denominator. Now, the thing that fascinates me and entertains me in no end is the reason they reject African data is they say we can't count. And maybe we can't count, but they definitely can't divide. So 679 patients were randomized in each group, which were called the intention to treat group. And one group got ivermectin and one group got placebo. So they were randomized so that they were the same number of women and the same number of men and the same number of diabetics and the same number of patients over 60 and all of the criteria. So they compared 21 deaths in the ivermectin group out of 679 intention to treat patients and to 24 in the placebo group. But only 288 completed in the placebo group. And this trial was run in South America where ivermectin is over the counter. And they did not use equivalent tasting substances. So the groups were not blinded. They knew whether they were taking ivermectin or they were taking placebo. And why would you stay on placebo if you were getting sicker, if you can walk down the road to the chemist and go and get the real thing? So in actual fact, 21 people in the ivermectin group out of 624 died, which is 1 in 30. And I'm not surprised because they used too little and they withdrew treatment earlier. And we have unpublished data in Zimbabwe to show that there's about a 12% death rate if you withdraw ivermectin on day 3. Whereas there's a 100% survival rate if people use it for 10 days at home. And then in the placebo group, 24 people died out of 288. That's 1 in 12. That is not a clinically insignificant difference. And when we reanalyze the data in their own trial, it was their data. And when a group of 77 doctors reanalyzed that data, we actually demonstrated, it's 59.6%, I think. But in actual fact, even when you give too little too late as monotherapy, you still had a 60% reduction in mortality with a p-value of 0.00089. So let's say 0.001. So not only have the authors of the Together trial made a fundamental error in calculating the mortality rate, but those who peer-reviewed this paper missed this mathematical error. Is this possible when mortality is the most objective endpoints? And one has to question peer review if peer review This is not a statistical error. This is a 16-year-old O-level error and even a lower junior school error. So I had an interview with Trial Site News, and I will reiterate what I said. As a doctor trained in Southern Africa, because I've worked in Namibia and Zimbabwe and in South Africa in the Cape, and actually I've worked in Gauteng as well. I feel that I have the best of both worlds. I have the benefits of good training. My MRCP is from the Infection and Immunity Department at St. Bartholomew's Hospital in London. But my real world experience was Groote Hospital, Victoria Hospital, the Frere Hospital in the Eastern Cape, Zimbabwe, and in Namibia. That's where I actually learned medicine in terms of hands-on medicine. And I know I'm not alone because a lot of people will say it one-on-one, but I think that it's actually quite insulting to be told by the credible academics and those in the civilized countries and the experts that our data is anecdotal and unreliable when they can't even get the denominator right. So the doesn't add together trial, doctors in low and middle income countries openly questions the results of the together trial, noting that the conclusions drawn by the media could seriously affect the ability of hospitalized patients to access ivermectin, which did happen, and many people died as a result of not being able to access this life-saving drug in hospital. And I'm afraid this is where the media are actually culpable. So let's get into what I can say I know because I live in Zimbabwe and I lived it. So all of the proof of a pudding is in the eating. In other words, the proof is in the real world results. So this is a CT scan taken on the 31st of March 2020, right at the beginning of the pandemic. Now, the expectation of a CT scan in terms of people who have managed this disease is that in 3 to 5 days, you would have a whiteout. So on the left, we have 2 cuts through the lungs. You can see the ground glass. Appearance, you can see the crazy paving that they describe on the CT. And this patient is treated, in this case, nebulized. This was before ivermectin. And on day 3, he was at home, talking, laughing, behaving normally, with dramatic improvements on his scan. We tried desperately to publish this. We were never given ethics approval. We were never allowed to publish this case report. Now, these are 4 patients after ivermectin was approved in Zimbabwe. And what I can tell you about these 4 patients is that I'm absolutely certain of these results because these patients were WhatsApping their oxygen saturation readings to us. And you can see that within 24 hours, every single one of these patients is saturating over 80%. And if you're over 80%, because ivermectin protects cardiac myocytes and because it breaks down clots, we can almost guarantee that the patient will survive. Anybody who presents with SATs of under 50% was generally not salvageable. I only saw about 2 patients who survived. And we then compared the Zimbabwean data, which is the red line, and it is combination therapy. And it's very important, if you listen to Professor Barodi's talk, that you must use multiple drugs for any organism that replicates inside the cell. And I got my protocol from Professor Barodi in Sydney, as did Dr. Sabine Hassan, who was practicing in Malibu, and we didn't know each other existed until I was contacted by Dr. David Scheim, who said, your data replicates Dr. Hassan's. And he produced this graph. This graph is produced by people with PhDs in mathematics. So we can see that the standard of care, which was used, and was trialed, we can confirm what the solidarity trial showed. If we look at day 0 all the way through to about day 7, we can see that the oxygen saturations do not improve. And when they do improve, they certainly do not return to normal. The Nigerian data with Babaloli basically shows that if you give ivermectin with vitamin C and zinc, you get a significant improvement by 24 hours, and by about day 6, 7, your patient is pretty much back to normal. But when you add ivermectin, doxycycline, and zinc, which was done in Malibu and in Harare, which demographically and geographically are on opposite sides of the globe and are possibly even different planets and alternative universes, we got exactly the same data. So the p-value, which is the probability that we got the same data in different corners of the globe, the probability that that happened by chance is 1 in a billion. Now, big numbers are hard to comprehend, but 1 in a million is a pretty low risk. 1 in 1,000 million is as close to not being wrong as you can get. So doctors who have PhDs in mathematics from the Massachusetts Institute of Technology calculated these graphs. There is less than a 1 in a billion chance that ivermectin does not work. And what that tells me is that the Solidarity trial, the Principle trial, and the Together trial may have large numbers and statistical significance, but they are clinically completely insignificant. And this is an old slide. It is from 2023. But COVID has effectively gone in Zimbabwe. Our last wave of any interest was Delta. And there was a bit of a blip with Omicron in December 2021. But we have not had this massive death rate and what's happening elsewhere in the world since 2021. July, August 2021 was horrendous. We are now approaching July, August 2024. It's been 3 years. These graphs are not the same in Japan, in Australia, in New Zealand, in the UK, in the US. So I don't understand why we should be doing what people in Geneva or in the US say we should be doing when our mortality rate is 1/500th of theirs. And to say that African data is unreliable is, I think, insulting at best. So I want to also discuss constructive conflict. So doctors have been demonized, and I'm sure many on this call have been demonized for their opinions. And this is not constructive. We share many values with the medical councils. We share the desire to protect patients and to give patients the best possible care. And if we were curious to find out the truth, we would dissolve the rigidity and the polarization. And tolerating and exploring different opinions is, in fact, the way forward. So how do we turn conflict into connection? So managing conflict is critical for a health relational system. It's also critical for a social system and a political system. And the situation of being in an argument is not in and of itself negative. The how is important. So how conflict plays out, how people are shut down, how negative conflict has arisen results in negativity or polarization if it's managed badly, or it results in resolution of a conflict, which at this stage has not happened. But the form is more important than the content necessarily when tempers flare. And it's very important to not deny the validity of another person and flatten another person. It's not going to result in a good outcome. The objective is not to win. The objective is to give the best possible patient care and maintain relationships within the profession. So what happens when we head towards disease X, which may very well occur in winter in Africa, in sub-Saharan Africa in 2024? So we will be going into it. Well, Dr. Peter McCulloch has concluded we can't vaccinate our way out of future outbreaks with untested, unsafe genetic vaccines. And the data coming out all over the world means that we in Zimbabwe are very, very blessed to have avoided the genetic injections. And our focus must be treatment, 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 and early treatment. And this is from December 2020. We know that with this virus, if it does come back in the middle of this year, in our winter, we know there's a viral proliferation stage, we know there's a cytokine injury stage, and we know there is a thrombotic stage. And if we treat each of these modalities, we get 100% survival. This is unpublished data. It may be published, but I doubt very much at the moment we'll get it past ethics. And the best treatment for a patient is based on your clinical experience. And please, as doctors in Africa, don't underestimate that. I did more chest drains in one night in Victoria Hospital than I did in 20 years in the UK, Dubai, and Australia. I did one chest drain in 20 years between 1993 and 2015. So people don't even begin to understand how late patients present here and how severely they present. And African doctors have enormous clinical experience and more than 10,000 hours of dealing with critically ill patients and saving their lives. The best available evidence may just be one case report. It might be another doctor you work with's opinion, but it's better than nothing. And waiting for these large double-blind placebo-controlled randomized trials, especially when the trial's conclusion does not match its own data. A large double-blind placebo-controlled randomized trial that comes out of the Solidarity trial, which is produced in 6 months, and the principal trial, which the conclusion doesn't match the data, is not good evidence, no matter whether it's the gold standard or not. It's a poor quality trial. And an expert opinion, a case study, which I showed you with the CT, and a case cohort study that is well done is far, far better than a large double-blind randomized control trial. And we must never forget that our patients have needs and preferences. And if they ask us not to be admitted to a red zone in hospital and to be ventilated, that is their preference. And the best possible outcome for a patient, and this slide is actually a litigation slide. It's not, although it is clinically relevant, but the best way for you not to be sued is to use your clinical experience, the best available evidence, and what the patient actually wants. But it's also the right thing to do. It is the right thing to do in medicine. For many of us, this is why we did medicine in the first place. So we've been through the African Solutions for African Problems. What is the worst possible thing that could happen if we use this medication? Well, we could have a population of parasite-free patients with a little bit of a visual disturbance that will peak at 4 hours and will be gone in 24. And if we look at the use of silver, it does not affect dark-skinned people. And you can't, the only way that you can die of either of these two drugs is to probably drown in them if you can afford that. I'd like to dedicate this talk supporting Dr. Shankara Chetty, who goes before the HPCSA on Monday. The charges are yet to be defined. I went to a wonderful service in Harare, and I will go through that in a minute. But what Dr. Chetty did was he treated the cytokine storm by day 8. Because the virus doesn't kill you, the cytokine storm is what kills you. And it's easy to prevent and treat. He used a lot of antihistamines, and he had an 8-day protocol. and of 14,000 patients, all of them survived. He doesn't have charges yet, and the Good Friday service rang in my ears because Pontius Pilate says there is no basis for a charge against him, and his crime was that he spoke the truth. So getting back to constructive conflict, demonizing certain doctors is not constructive, and we need to remain curious, and we need to be discerning about the data, and we need to be confident as African doctors, because many of us have first world, and I use that in inverted commas, training, and we've come home and we've shared this with our colleagues who have more experience than the rest of the world will ever get. And we need to stand up, Africa. It's definitely our time. So I'm going to end it there because I'm conscious of time and I'm conscious of questions. I'm also struggling to get my glasses on under my earphones because I'm not very good with this technology. And I would like to open the floor to any questions. Pride, or whoever's on the call, I'm not seeing the chat. Are there any questions to the chat? Yes, I've got them now. Seems that most people are looking for a register. So Dr. Shane has commented. Thank you, Jackie. Shankara is a hero. One of the things I'd like to say is to please ask people to not call anybody heroes, because we aren't. We simply did our job, okay? And to call someone a hero, and I think Shankara feels this way as well, we've discussed a lot of cases over time. And that is that patients have a responsibility for their own health. To call someone a hero or a savior has the implication that it is our responsibility to save someone. And it actually isn't. It is our responsibility as doctors to give people options and to tell them what the outcome of each option is likely to be. The other danger of calling someone a hero, Kobe Bryant says that haters are a good thing to have because haters only hate the great. And the haters hate in direct proportion to their own lack of self-esteem and their own inadequacies. But they do report those of us who were doing our job to the medical councils. And my very first disciplinary hearing was the 29th of March, 2021. And it was the burial day of my aunt, who was like my sister, and I was not allowed to attend the burial because I had to go to the disciplinary hearing because I was a hazard to public safety, according to our medical council. Now, I need to make it clear that our medical council were the problem. The Zimbabwe government stood by me the whole way through this, and I cannot give anything but praise to Air Commodore Chimedza and to Professor Ndurukwa for their support in ensuring that the people of Zimbabwe were never exposed to genetic vaccines or genetic injections, and ensuring that ivermectin was widely available in this country and still is. So, Shanae, I would ask you to avoid the word hero because inadvertently you end up making sure that we have many spears and weapons aimed at us by people who don't like that word. Perhaps we were warriors. Certainly some of us have been named as the 7 samurai that were named by Professor Satoshi Omura, who named the samurai who were prepared to fight for patient care. But I'm definitely not a hero. You are responsible for how you treat your patients, and your patients are responsible for whether they listen or not. And we must start making healthcare workers and patients accountable for their own decisions. But thank you for the comment anyway. So the mechanisms of action. What is the mechanism of action of ivermectin? There are well over 22 mechanisms of action. They are grouped into 4 categories. One is antiviral. So ivermectin is a zinc ionophore. It allows zinc into the cell. So is hydroxychloroquine. And therefore, when zinc gets into a cell, I can show you slides, mRNA-dependent mRNA polymerase is inhibited. So the bottom line is that ivermectin and hydroxychloroquine and zinc together will shut down the replication system of the virus. Okay. So there are other antiviral actions ivermectin has, but I can't go through all 22 of them. So there are 4 antiviral actions. Then it also stops the cytokine storm. Interleukin-6 is very important in that pathway. Many people measured interleukin-6 as a prognostic marker. It definitely reduces interleukins. I personally take ivermectin twice a week. I have a number of sports injuries due to some reckless behavior on hockey fields and on sports fields, and also tobogganing down Jamison Hall steps, which seemed like a good idea when I was 19. So there's no question that inflammation goes down, in my personal opinion, but there's huge amounts of evidence that it is anti-inflammatory. So we have antiviral effects, we have anti-inflammatory effects. The third effect is anti-hemagglutination. Boshi et al. Wrote a paper, it was in vitro, they took red cells, they added spike protein, the red cells clotted. If you pre-treat with ivermectin, they don't clot. If you treat the clot with ivermectin, it breaks down. In the clinical setting, if you give ivermectin, the D-dimer rockets up. And at the beginning, I thought patients were going to die. So the very first patient that was treated by his own choice, he went and bought his own medication, and his daughter went and bought it for him, but I did not stop him from taking it. And his D-dimer on in the evening was 2,400, which was clearly high. So he was anticoagulated with rivaroxaban. We gave him Clexane first and then rivaroxaban, and he also went on to aspirin. And then in the morning, his D-dimer was unrecordable. It was over 10,000. So I phoned the home nurse because he went home on home oxygen, because our unit was simply a stabilization unit with the intent of going to hospital at home or to hospital. Most patients refused to go to hospital, so they were managed with home nursing and home oxygen. And I phoned the nurse and I said, look, you're going to have to switch to palliative care. This guy's toast. His D-dimer is unrecordably high. And she said, but he's sitting up in bed and he's having breakfast and he wants to go for a walk. And I just said, well, that's not possible. And then when I thought about it, the D-dimer is a marker of clot breakdown. So the reason his D-dimer went through the roof was because the clots were breaking down. And the Boshi paper was published subsequent to that. So we must never also forget the power of our own observations. What we demonstrated in that man was he went from rapid AF and a thready pulse into normal sinus rhythm with an excellent pulse waveform and a normal blood pressure, having been hypotensive over 6 hours, and he reperfused. That is only possible if the clots were breaking down. And his D-dimer went through the roof because fibrin degradation products shot up because the clots were broken down. So one of the mechanisms of action is the spike protein is highly positively charged. Red cells are negatively charged. You get hemagglutination. If ivermectin coats the spike, which we know it does, and is predicted to do under computer modeling, once it coats, electrostatically coats a positively charged glycoprotein, then the red cells can maintain their negative charge, they repel each other, and they can flow. So its main mechanism of action, as far as I'm concerned, in terms of being life-saving in end-stage patients was that it caused clot breakdown. So we've got antiviral, anti-inflammatory, anti-clotting, and the fourth mechanism of action is the most interesting. In a published study from 2017, Nagier demonstrated that there were small molecules that allowed cardiac myocytes, cardiac cells, to produce ATP in conditions of low oxygen. That means in a hypoxic patient, the heart can still produce ATP. Now, we are very, very aware, those of us that were in the front line in 2020, 2021, that most patients died of a hypoxic cardiac arrest because the heart wasn't getting enough oxygen and they went into a cardiac arrhythmia, usually VF. So if we can allow the heart muscles to pump without oxygen, it's a bit like your fuel injector pump being able to run your engine without the diesel turbo or the turbo on. It isn't requiring oxygen in order to be able to pump. And Natia Mhladla demonstrated that patients he put in a ward for palliative end-stage care that were given ivermectin because there were not enough ventilators, nearly all of them survived, despite going overnight with SATs in the low 80s. So the mechanisms of action are antiviral, anti-inflammatory, antithrombotic, and cardioprotective. And in end-stage patients, we've had a conversation, what is more important, the cardioprotective effect or the antithrombotic effect? And what I would say to you there is, what is more important in calculating area? Is it the length or the breadth? And the answer is that you can't calculate the solution unless you use both. And it is the same with the whole of infectious disease. We can't use monotherapy, and double-blind, placebo-controlled, randomized trials using monotherapy should be ethically not allowed. They are unethical. We've known since 1952 that combination therapy works in TB. So why we would use monotherapy? Because if we used it in HIV, Helicobacter, or in malaria, we would be deregistered and disciplined. And it makes absolutely no sense. We need to think about these things. So ivermectin's mechanisms of action in end-stage patients are antithrombotic and cardioprotective. Thank you for that question. It's a very important one. So, Dr. Rapiti, good to hear you on the call, and I'm really sorry I didn't get you to speak on the last call. Would you like to speak on this one and talk about your own experiences?
Yeah, hi, Jackie. Yeah, I wouldn't mind sharing some things. And I'll start by saying that this is a community that accepts controversy. So I'm going to say that the Delta strain is completely different to the other strains, and lots of us are making this mistake because in the earlier days, when you had the wild type and the alpha strain, can you hear me? Sorry.
I can. I'm
Hello.
just telling somebody to not come in and have a conversation with me.
Oh, okay. So what I was saying is that I didn't have access to ivermectin in the earlier strains, right up until alpha and delta. I just used I use steroids. And I use erythromycin. And I can tell you that during those strains, they were very mild. I don't think I had 0.001% deaths. So they were very self-limiting. This thing about the 8-day story would not apply in the Delta strain. I picked this up because by day 2, day 3, people in the Delta strain were coming to me kind of breathless. And I evolved, and I agree with you that we need to look at clinical signs, not x-rays and scans. And I picked up, and I think many people are aware of my 8 points of clinical symptoms and signs that you pick up without an x-ray, and you pick up early involvement of lung pathology. And anybody who says you got to test ivermectin to see for its efficacy does not understand the pathology of ivermectin. You quite rightly mentioned that it is viral, anti-inflammation, cytokine storm, and the clotting aspect. So you use one drug on a multi-pathology drug is absolutely stupid. So I wouldn't trust any trial. The one trial where they started on day 3 was too late. I can tell you the Delta strain, on day 1, I warned all my patients on my videos that the minute you get the symptoms, you go on ivermectin, you go big time doses, because it was multiplying 70 to 100 times more than the alpha strain. So my reasoning was that if you had a high multiplication of a virus, you use high doses. That's a teaching in medicine. With any infection, you use high doses. And I was brave enough.
101.
Yeah. Well, the thing is this, I used doses of 0.8 and 1 milligram, because I thought if I'm going to give them a diarrhea, so be it. But if I'm going to underdose and send them to death, that's stupid. And I can tell you not one of the 1,000 or 1,100 people that I treated had any adverse event, and I had a 99.97%. I had 4 people with 35% oxygen. I got them better at home. 2 of them discharged themselves from hospital. The one guy I mentioned with a 42% was a gentleman who was admitted into hospital, wasn't seen by a physician for 2 days, and was told by the nurse, "We don't treat elderly people." And I treated this guy on the phone because I'd mastered it. Where the expert, not the heroes, I agree with you. We're the masters that are not being recognized. And this guy is 3 years down the line, and he's 75. He's had COPD, and he's had a heart problem. So it's all of the rubbish that you're old and you're overweight. And I don't discriminate according to age. I've treated a 90-year-old lady of the Omicron strain, and she had a whopping, and there again, Omicron was completely different. These people had bad pneumonias after 3 weeks, and they could walk about. But with the Delta strain, you waited 1 day, your oxygen level from 95 would drop within about 2 days to 80%. But with the Omicron strain, it will stay at 90%. So, we need to treat each variant according to its presentation. So when people talk about predicting and using, you got to change your methodology, your treatment according to the clinical presentation. And no fool sitting in an ivory tower looking at the microscope, looking at a virus can tell you how this virus is going to present. Because clinically, I would agree with you. Statistical significance is not as important as clinical significance. So yeah, I agree with you. Now I would think that ivermectin is a good drug, great drug, but it's got its limitations. It has got anti-inflammatory properties. I use big doses of steroid, and this is a problem. I use up to 100 tablets a day, almost 1 to 2 milligrams. If they had diabetes, type 2, I used things like insulin. I got them better. This is the whole point. And I had some really very sick people, with bad diabetes, and I used steroids, and it worked extremely well. Yeah, I've got a tremendous amount of experience with this. I'm using ivermectin on. I've had about 4 patients with, or so far 10 cancer patients, and I've treated with ivermectin. I had a stage 4 recently. Was told by Gridiskia, you got 3 weeks to live, and in 3 days on my ivermectin protocol, I use nitrocanase, and I use vitamin D is not spoken about. And within 3 days, this guy was sitting up. It's 1 year down the line. The Gridiskia is now puzzled. What happened to his cancer? I said, just go and tell them you prayed, because I don't want to end up like Shankara. Tell them you don't know who's this guy. And I must say, I've got some respect from Gridiskia. We mustn't be afraid of speaking the truth, but be careful how you say the truth. Don't open yourself up to an attack by these evil guys. And the one thing that I would like, if you don't mind me mentioning about the Together trial, was a lot of rubbish, because it was not double blind, because one was given for 14 days and the other was given for 3 days. Which fool wouldn't know which one is ivermectin? Then the other thing is the placebo also got vitamin C in big doses, and we do know vitamin C has helped. So it was not quite placebo. So, and then to give the drug on day 3 in the month of July when Delta strain, by my book, was absolutely stupid. By that time, by day 2, you were getting a pneumonia. So I disagree with Dr. Chetty when he said 8 days, because my patients would have died. I've seen people come to me 5 days and they ended up with 60%, and every day could add a week to 2 weeks to your infection or your complications. So yeah, look, there's a lot I can say, Jackie. I've got 4 years of experience.
I agree with everything you've said. On something Shanae said, which she saw in terms of seeing the Delta strain, we never had genetic injections up here, and Delta was an absolute nightmare here.
Yeah.
So I would disagree. I agree with you that Delta was a completely different beast. I think it replicated much more quickly. If you do the maths, if you take a 4-hour doubling time, 1 million, 2 million, 4, 8, 16, 32, 64, 128, and you can carry on, you'll go from 1 million to 2 billion in 72 hours. So every 4-hour interval that you delay treatment, you need to double the dose of whatever you're giving. When we did our protocols, we were very clear to explain to our patients the concept of sequenced multi-drug therapy. So the tests that we did 4 tests in patients who didn't have any money. And those 4 tests were full blood count. We wanted to know how low the lymphocyte count was and how high the neutrophil count was, because a high neutrophil count meant that we needed to add antibiotics. We did an LDH, which was a marker of lung necrosis. We did a CRP to decide whether we were going to give steroids or colchicine or both, but an anti-inflammatory or not. And we did a D-dimer to decide whether we were going to anticoagulate, because obviously anticoagulating patients comes with its own risks. And you don't anticoagulate patients on day 2 of their illness unnecessarily if the D-dimer, if they've got a bit of a runny nose and nothing's happened yet, but granny's just died from COVID. So I think that I haven't showed a number of slides. I've got a lot of Peter McCulloch slides where he talks about sequenced multi-drug therapy and individualized therapy. So you must risk stratify your patient. If you have got a 58-year-old with diabetes who is obese and hypertensive and is very high risk, you go straight to antiviral, antithrombotic, and anti-inflammatory with multiple drugs. If you are dealing with a 16-year-old that has just been on a houseboat with a bunch of people who got a bit of flu and has a runny nose, you manage that patient with antivirals, and you may be able to manage that patient only with vitamin C, D, and zinc, which is Ian Brighthope's nutraceutical preventative protocol. So individualized treatment, but the most important thing is doctors have phoned me and they keep saying to me, give me your protocol. And I keep saying, there isn't one. You need to individualize treatment. It is a triphasic disease and the phases overlap. So if they are in the viral replication stage, which will be over by day 7 or day 8, and in Delta, it probably would still be going on, but if they're in you must treat with antivirals in the viral stage. You must treat with agents that have anti-inflammatory effects in the anti-inflammatory states, and you must anticoagulate, and you must also manage heart failure. We made it very clear that an insulin infusion was absolutely critical in a diabetic with a blood sugar of 35, or he was going to die. So you had to manage what you saw like a critical care doctor, and you couldn't be a specialist. You had to be a generalist. And if it comes back again, we are going to have to not have to understand in intricate detail the mechanisms of action. We need to be talking to our colleagues and say, what the hell is working? And then we all collaborate and we decide what's working, and we can work out why later, provided it is a safe and affordable drug. So the criteria for treatment is the drug must be safe, it must be affordable, it must be available, and it must be seen to be effective in at least a few patients anecdotally. and we can run the double-blind placebo-controlled trials later if you can get ethics approval to do them, because a lot of people, including Tess Lawrie, say it would now be unethical to do a double-blind placebo-controlled trial if another form of Delta hits us. So thank you, Robert. Your points, I agree with all of them. And we could talk about this ad infinitum. But I think the most important and pressing issue at the moment is that the public are aware and the doctors are aware that the medical councils are not acting in the best interests of either the patients or the doctors that actually pay them to discipline them. And how we resolve that conflict becomes important, because the more we polarize, the worse things are going to get. And it's a difficult road ahead, but the more that this sort of thing is spoken about and shared, and I think things are coming together. The FDA have settled out of court, which is effectively an admission of guilt, and they are taking down all their social media posts that threaten ivermectin. And they've never, ever settled out of court before. But clearly the FDA being found guilty of fraud has global implications, because our authority and your authority has multiple drugs that are very good in emergency care, that are licensed in our countries because they are FDA approved. So we're getting into a huge mess. But I think the way out of the mess is to go back to basics and to have platforms where we can openly discuss this, and where doctors that are curious can hear the truth. And we might not be right, because my opinion may be wrong. And I'm quite happy for someone to convince me that I'm wrong, as long as they can convince me that I'm wrong using a logical argument. The only reason I go on about ivermectin, because there are other substances that I'm much more interested in, including Artemisia. But the reason I go on about it is because of the negative publicity campaign. And the one thing I will say about ivermectin is it is the only one of the agents that covers everything. It's antiviral, anti-inflammatory, anti-thrombotic, and it's cardioprotective, whereas steroids are only anti-inflammatory, and rivaroxaban is only anti-thrombotic. And doxycycline is both antiviral and antibiotic, but nothing else covers everything. So if you could only take one drug, that would be it. But as Professor Barodi says, combination therapy, combination therapy, combination therapy for an intracellular organism. And whatever disease X proves to be, combination therapy with empirically tried medications and communication between doctors that actually follow their oath will be the way forward. So with that, I hope that we've covered it. I am aware that we have gone 15 minutes over time, so I would like to end it there. In terms of speaking about cancers, Dr. Wucha spoke about cancer prevention last week. Intellectus Campus will be running a course in cancer prevention that will be designed for survivors of cancer or veterans of cancer. It will also be designed for spouses of people with cancer, spouses and people who care about people who have had cancer and don't want to relapse, or people who just want to prevent it from happening in the first place because they think they're high risk. But we'll be talking about that on a future group. And that course will not only be for doctors, it will be for anyone interested in wellness. You can be a nutritionist, you can be a chef, you can be a psychologist or a life coach. You will still get the information required on what dietary measures need to be taken, what toxins need to be avoided, and what nutraceuticals are required and at what dose. So I'd rather stay away from the cancer thing at the moment. The message of this is really to be careful of these enormous trials that they are running in multi-centers across the globe. I cannot see how 2,000 researchers can get a paper out in 6 months. It can't be, it's cognitive dissonance just hits me with that. And if we're going to be making decisions on our patients that we are sitting opposite, then we must be making it on data that we can trust. And I think that's our data, our own